But so we'll just be diving into a little bit more, talking about, what is stroke and how do we get onto that process of adjustment to life after stroke. So to start us off, I always like to mention that I'm coming from both the Minnesota Brain Injury Alliance and the Minnesota Stroke Association. You may hear us referred to as one or the other or both. I like to say we are two organizations served by the same group of staff. And everything
Cool.
we do for the state of Minnesota is entirely free, making it really cool and really accessible for folks. And then our mission is really all about how do we raise awareness? How do we enhance that quality of life for all people impacted by brain injury or stroke and dealing with its sudden or maybe its more long-term consequences? So to give you a little bit of a scope of what we'll be talking about today, we're going to begin with a really quick overview into what we do at the Stroke Association. So we'll cruise into really what is brain injury? How does it relate to stroke? What are those signs and types of a stroke? Then we'll move into how things change and what that recovery process looks like for survivors, leaving a good amount of time to talk about that adjustment process directly and leaving time for coping strategies. So to kick us off, I always like to start with just a little bit more of what we do and how we could be of support to the folks on the call today. So I'll go into the most detail into those first three services you see: resource facilitation, education and outreach, and public policy. Outside of those big three, we also have our case managers, the folks who oversee those home and community-based services provided to someone through their waiver program or medical assistance program. And we have volunteers. Now, I like to say these volunteers help us twofold. I have a number of volunteers that we call part of our Speakers Bureau, and these folks come out with me when I'm presenting around Minnesota so they can share a little more of what does it mean to be a stroke or a brain injury survivor and give that lived experience. And we have a number of other volunteers who work with us with the goal of regaining skills related to competitive employment. Let's say it's been a year. That person had their stroke a year ago. They're hoping to get back to work, but they're not exactly comfortable jumping in at full force. Then we invite folks to come work with us, regain some of those skills, and then we can send them out with a stellar recommendation for wherever they go next. So plenty of opportunities on that end. So the big one I like to mention is resource facilitation. Simply put, RF, as we like to call it, is 2 years of telephone support. So really what these folks do is they're really there to help you navigate those most challenging aspects of recovery and really help you find the resources that can be beneficial throughout that recovery process. So to give you a for instance, a lot of times it would be you're getting a call from your facilitator. Hey, last time we talked, you mentioned you were on the hunt for a new support group. Maybe you're looking for a place like Inspire, or getting set up with a new physician, or trying to find a new activity group, and really help you navigate where are those things, how can I get a hold of them. My personal favorite part of this program is we have a different of these facilitators geared towards each of the major regions of the state. So no matter where you are in Minnesota, we've got someone who specializes in your region and knows what kind of resources are in that area. Not to mention, this is just a nice person who understands brain injury, understands stroke, and can serve as that listening ear, not only for you, but also the caregivers in your life, professionals or family members you might be working with, or really anyone in between. So don't hesitate to give us a holler if there's more we can do on this end. Like I say, this is a 2-year program, but that is 2 years from the point of referral. So that could be a 1-year-old injury, a 10-year-old injury, doesn't matter now. And then to give you a general sense of the various outreach events we like to do, you'll see quite a variety, but ranging from things like our support conference. We do those twice a year, and it's a great way to meet other survivors, families. Also, our Strides for Stroke and Walk for Thought fundraising events, our Mind Matters and Stroke Matters magazines, our professional conferences, our unmasking events, a real variety of others as well. So feel free to visit our website if you ever want to get out there, meet some more survivors, and engage more with these events. And then finally, our policy folks. Now, the way we want to go about policy is we don't want to say, this is what's important to the community, because ultimately we don't know. So instead, we ask our survivors what's really valuable to you right now and how can we work on it. So some of the big things that our community has let us know is really important to them would be protecting medical assistance, also goals to reduce those income and asset standards that tend to impoverish people that are entering the MA system. Also more stroke and brain injury prevention resources and more affordable housing resources. And one of the big ways we go about this is with our citizen advocate program. Now, to keep it simple, you can think of that program like 4 to 6 weeks of classes meant to help a survivor learn, how do I share my story? How do I do so when I'm under time restraints? How do I do so when I'll be speaking with a legislator? And then we get folks to the Capitol to share their story and really share their experience to shape policy. So these folks are always working throughout the year, developing stories and getting folks to the Capitol. So don't hesitate to give us a shout if you want to get out there and talk a little more, whether that's state or federal policy. So that gives you a little better sense of what we do. And this brings us into kind of the meat of today's conversation. Really, what are we talking about when we're saying acquired brain injury, stroke, and all these things in between? So the way you can think about this is any injury to the brain is really an ABI, or acquired brain injury. So you can think of this as any injury you weren't born with, it didn't happen throughout the birthing process, it wasn't passed down genetically, and it's not going to get progressively worse over time, or it's not degenerative in nature. And when we look at ABI, it is the second most prevalent disability in the US, falling second only to depression and estimated to impact at least 13.5 million Americans. So very, very significant. We can then break this down a little bit further with the traumatic and non-traumatic halves of this umbrella. So when you see a traumatic injury, this really entails a blow to the head. That could be the head hitting something or something hitting the head. In this case, something like a fall, an assault, a sporting injury, or motor vehicle accident. Whereas on the non-traumatic side, we see those more internally charged events. So things like stroke, maybe a lack of oxygen, what we call a hypoxic or an anoxic brain injury, also a complication during surgery or an infectious disease, even exposure to certain toxins or pesticides. So a little bit more on the internally charged side of things. As we talk about those traumatic type injuries, there are a lot of different phrases you'll hear thrown around. I think two of the most common ones we hear would be closed and penetrating. And you can think about them just as simply as that. A closed injury is any injury that does not break through the walls of the skull. And a penetrating injury is any injury that does break through the walls of the skull. You know, something typically like a bullet or a knife entering in and causing damage to the tissue underneath. Three of the other phrases you'll hear very often is mild, moderate, and severe when we're talking about that classification. Now, what I like to say here is really for all types of brain injury, those classifications are meant to reflect what happened immediately following the injury and is less so reflective of what the long-term symptoms will be. So in many cases, someone may have a mild injury, but more moderate symptoms. Or maybe they have a severe injury, but more mild symptoms. Really depends on the person and in what way their brain has been injured. But we're really going to ask those three questions you see at the bottom there. How long was the person unconscious? How much of a coma state were they in? And how much PTA or post-traumatic amnesia did they experience upon waking up from that unconscious state? And you'll see each of those getting more intense or having a longer duration with a more severe injury type. When we talk about the definitions for stroke, you can really think about it as one of two major things. Either a blockage of blood moving up to the brain or an over-release of blood into the surrounding brain tissues. In either case, resulting in the death of those surrounding brain cells. For most folks, they'll have this experience begin as a feeling of weakness, numbness, or a loss of feeling, typically on one half of the body. And you may hear stroke referred to as a CDA, or a cerebrovascular accident, or a brain attack, similar to how we say heart attack. Now, some of the statistics. In 2023, just in Minnesota, approximately 140,000 adults reported having a stroke in their lifetime. And stroke is the more than 4% of all deaths in Minnesota are the result of stroke, and stroke is the fifth leading cause of death across the state. And right around every 40 seconds, someone experiences a stroke. And every year, nearly 800,000 people experience a stroke. But there are some disparities when we look into different groups. Specifically, from 2018 until 2021, stroke death rates were significantly higher for our Asian, Pacific Islander, African American, and Native American groups, anywhere between 30 to 40% higher. And we see the lowest rates of stroke death in our white and Hispanic populations across the board. So this brings us to a little bit more on what the signs of a stroke are and what the different types of strokes are. So of course, I'm sure you're all pretty familiar with Be Fast, this one being the newest guidance for recognizing those signs of a stroke. So as we talk about the signs of a stroke, it's helpful to keep in mind that most strokes are going to impact one half of the brain and not the other. And of course, our brain controls the opposite half of our bodily function. So our left-sided brain controlling our right arm and our right leg and vice versa. So when we see these, they'll often be focused on one half of the body. For instance, balance loss for B, where the balance loss will typically be in one of the legs and less so in the other leg. We might also see eyesight changes. This could be changes in one or both of the eyes. And then the facial droop. I mean, I think that's probably the biggest hallmark of stroke. You ask someone to smile, one half of the face goes up, the other stays down. Arm weakness could be another big one. Often it'll be something like someone's carrying something to the table, maybe that arm goes and they drop it. And speech difficulty. Now, this is both the production and reception of speech. So maybe you're talking with me and suddenly what I'm saying starts to sound an awful lot like mumbo jumbo. Well, that could be a sign of a stroke on either half of that coin. So make sure you're paying attention to see if any other symptoms arise that could help you better indicate where is this coming from. And finally, T. So you may see T listed as time loss is brain loss, as we have it, or you may see T listed for terrible headache, which is a really clear indicator of one of those bleeding type strokes. Now again, these feelings are typically going to arise suddenly and unexpectedly. You know, if you have consistent balance issues in one of the legs, then that certainly doesn't mean you're perpetually having a stroke or stroke symptoms. But if you're seeing these things arise and it's not something you're used to, then probably good to get it checked out. So that could be that weakness or numbness throughout the body, especially if it's only on one half of the body. It could also be that trouble speaking or understanding, trouble seeing with one or both of your eyes, that loss of balance, coordination, confusion, dizziness, or that severe headache. But there are some unique symptoms that we see specifically in female groups that we don't see as often in male groups. Now, excuse me, I think it's important to note that while stroke is the fifth leading cause of death across the United States, it is the third leading cause of death for women in particular. And we do see double the amount of women die as the result of stroke that die due to breast cancer every year. So very significant. And some of these unique symptoms can often be things like that sudden shortness of breath or difficulty breathing that may or may not be paired with a loss of consciousness or fainting. It could also be that slurred speech combined with confusion and disorientation. And for other folks, agitation, hallucinations, nausea, and interestingly, hiccups. Now, these hiccups for the person are really going to feel as though they're crooked. You can imagine it like we have our two halves of the diaphragm contracting our lungs, and one half of the diaphragm is impacted by that stroke, leaving the other one to act normally, and the person feeling like they have these crooked hiccups. And of course, that could be a pretty clear indicator of those first signs of stroke. And as we talk about the different types of stroke, there are a few different ones we'll cruise through today. We're going to start out just by really quickly talking about the ischemic side of stroke that makes up the large majority and is caused by a blockage in the blood supply. We'll then cruise into the hemorrhagic side, or the bleeding type strokes that make up around 13% of them. And then we'll end by talking a little bit more about mini strokes, warning strokes, or as they're called, a TIA, or a transient ischemic attack. So starting out with the ischemic stroke side. So an ischemic stroke is really where we have a blockage of the blood moving up to the brain. This is typically something like a clot, but it could also be something like a pinch in the artery or some other type of blockage. But what's happening is no oxygen can get to those regions of the brain, so it's really being starved of the nutrients that it needs, slowly resulting in the death of those surrounding brain tissues. When we look more at the hemorrhagic side, you can really think of this like a bleed in the brain as a variety of reasons. So this could be something like maybe a weakened artery rupturing, like what we see in the case of an aneurysm, but it could also be something like direct brain trauma. Maybe somebody gets into a car accident, they hit their head and they get a brain bleed. That'd be a little bit more of a traumatic side of the stroke. And an aneurysm, you can really think of like if this is my artery carrying blood up to my brain, and there's a mild weak spot along that artery. Now, that weak spot allows blood to move in and create a pocket or a little bubble. Now, hypothetically, any or all of us could have an unruptured aneurysm that's just kind of hanging out there and isn't too serious. The dangerous piece is when we have high blood pressure that's beating against the inside of that balloon that can increase the chance of it popping. Mm-hmm. We can also see AVM, or intravenous malformation, which is a mouthful, but simply put, is where we have a misconnect in the artery system, where typically we would have artery connecting to vein with capillaries in between. With AVM, it's straight artery to vein, increasing that blood pressure pretty significantly for the person. And the biggest indicator of a hemorrhage would be that thunderclap headache. I hear these described as a headache that gets to peak intensity or peak pain within the first minute. So it will kind of barely begin and then get very intense very quickly. So that could be a really clear indicator of that bleeding in the brain. Then bringing us to a TIA, or a transient ischemic attack. Now, you can think of TIA as a temporary stroke, a warning stroke, a mini stroke. All of these are fair. But really what's happening is we have a temporary ischemic blockage, or transient blockage, if you would. So this could be something like a clot that gets set in kind of the junction point of that artery. And then it's briefly blocking that movement of blood, but the regular blood pressure will eventually push that along and allow blood flow to resume. So for most folks, these are going to last right around 1 to 2 to 5 minutes, not very long for most people. But what's important to say is simply because that clot moved does not mean the clot is gone. And about a third of people who experience TIA will have a more major stroke within 1 year. So I always like to say it's better for us to be safe than sorry. This is certainly one of those cases. So if you see something like TIA, probably the best idea to just go get it checked out if you can, just to be on the safe side. Now, as we get to this portion of the session, I always like to say I truly understand that this is scary. I mean, none of us want to have our initial stroke. Nobody wants to be back for a secondary stroke. But now more than ever before, especially in the state of Minnesota, stroke is preventable, it is treatable, and it is beatable. Right now, we're at 96% readiness in the state of Minnesota for stroke care. That means if you're in 96% of the state, a stroke unit can get to you in a much more time-sensitive manner with a CT equipped in that ambulance, so some testing can be done en route to the hospital, which is excellent. We've truly never been in a better place for stroke access to care, but if we don't know what the signs are, it'll be a lot harder to get that help when we need it, of course. And this brings us to how things can change in the recovery process. What are the changes we see among survivors and within families? Now, before we get too much further, I think it's really important we say, once you've seen one brain injury, you've seen one brain injury. And it can be easy at times to jump to overgeneralizations and say, this person had an injury here, they're dealing with symptoms X, Y, and Z. But the rules are not that hard and fast. So once you've seen one, even if it's your own, you've seen one. So with this, we can talk a little bit more about what some of those changes are. So towards the right-hand side there, many of these changes will be cognitive. Changes in how we think, how we access our memories, how we work through tasks thinking-wise. It could also be the social piece, things like aphasia and how we communicate with one another. Not to mention the emotional piece, how we regulate our mood, how our emotions are more or maybe less reactive than how they were before. And for many folks, if not all folks, the sensory piece, where the lights, the sounds, the smells, even tastes can be overly stimulating compared to what they were before. And the one I like to save for the end is physical changes. And the reason I do is because among many brain injury and stroke survivors, we don't see a lot of those physical changes. And for many folks, this is a very, very invisible injury. Now, for this reason, folks with a brain injury or stroke that is more invisible, they're often not given the same respect, the same patience, the same grace that other folks might be with a more obvious physical disability. And then on the flip side, for our survivors who do have that more obvious physical change, they're often going to be facing the discriminatory action that goes along with being somebody who's physically disabled. So not exactly easy on either half of the coin, but good to remember that there's differences in both. And the recovery process is very greatly dependent on the individual and varies quite a bit based on things like their motivation, based on their diet, and a variety of other factors. It can be dependent on the severity of the stroke itself, be that mild, moderate, or severe category, but not always essentially going to be. Now, what we see is that recovery is fastest at the beginning. Folks can make really significant strides in those initial stages, and progress gets slower. It's always still possible, but slower the further out you go from the time of injury. And of course, this is why. Yeah, was that a question? No worries. So with that, you know, the recovery process is typically going to be, getting a little bit slower the further out you go. But that's why it's so important we try to start on those rehab strategies and work on those goals as early as we can. And with those rehab strategies, it's good to focus in one or two categories. So the first one being restorative strategies. To give you a for instance, let's say maybe I had a stroke and I lost my ability to speak as well. But I'm getting set up with a speech language pathologist. I'm improving that skill. I'm getting better as the days come. Now, that'd be the restorative side. We're looking to rebuild connections that are already there to increase our functionality. Whereas the compensatory side, to give you a for instance, might be maybe I lost my ability to speak as well, but I'm getting set up with a tablet that has some assistive tech on there to help me communicate. Now, that'd be more finding an accommodation or a workaround for that issue to compensate for what's been lost. And for many folks, they'll kind of be ebbing and flowing, using a little bit of the restorative, a little bit of the compensatory as things come up. But good to keep in mind that both of these can be wonderful strategies depending on what you have going on. And as we talk about the long-term recovery, it is truly always a marathon and never a sprint. And oftentimes, the first question we get is, when will I be back to normal again? And this is a really challenging question to answer because ultimately, we are our brains. And if the brain changes, we fundamentally change. And it's often not a fair expectation for that person to say, when will you be back to normal again? Because that's a lot of weight to put on somebody's shoulders who just had something very major happen in their life. So instead, we like to say, what is your new normal? Which really involves that you're recognizing your strengths and trying to highlight those as much as possible, while also acknowledging limitations and trying to reduce those limitations as much as possible, which is, of course, easier said than done, but ideally, putting a little bit less weight on your shoulders. And there's a nice quote here from one of the survivors we work with, Rick. This was a little over 10 years ago now. Recovery does happen. Doctors tell families that the recovery is a 2-year process and that survivor will plateau and it stops. Well, there are things that I can do today that maybe I couldn't do yesterday. The recovery never stops. And let me tell you, we work with Rick still to this day, and he is making tremendous improvements each and every day. So he's truly right. There's always potential for recovery, no matter the stage that someone is in. But this really brings us to our topic of, how do we get back on that road to adjustment after something like stroke? And adjusting to life after stroke often comes along with a lot of common feelings. Many of these will be things like anger, being frustrated by these new limitations that you weren't expecting to take on, or the uncertainty of saying, I don't know what this recovery timeline is going to look like for me, and I don't really know how to plan for the future because of it. It could also be the shock, that emotional numbness of not really being able to come to gravity or really come to terms with the gravity of the situation, often going hand in hand with denial and diagnosis rejection, saying, I don't want to be seen as different or lesser or changed, so I'm going to push back and say nothing has changed. And for other folks, the relief, saying, I'm just happy I survived. And finally, the bargaining, saying, I would just do anything if I could just talk again, if I could just walk for myself again, so on. And oftentimes, one of the first things we see among survivors is that changes in the survivor's experience. That could be the identity of that person, the self-esteem of them, how they control their emotions and behavior, and how they express and communicate with others. Not to mention things like their independence, what they can do for themselves, or what their spirituality is compared to what it was before. Now, it's really important that we give ourselves opportunities to discuss these changes with people we can trust and discuss potential changes that could arise in the future, that we were really not being caught off guard as things change as we do move towards our recovery. And grief and loss are some of these feelings that are really challenging to work through, especially in these initial stages. Now, I'm sure all of us are familiar with direct grief and loss. Maybe that's grieving like a loved one that you lost in that relationship. But it could also be grieving maybe a change in your mobility, a change in your career, your assets, your level of productivity. But there's also those aspects of ambiguous grief that are harder to nail down. The celebration of survival, but some aspect of the grief remains. Something like, I just don't feel like myself anymore. Our friendship feels different than what it was before, or I feel like I'm married to a stranger. And oftentimes, this is that profound sense of sadness that is not directly related to the loss of a loved one. And for this, there are less opportunities for external closure. So one of the best things we can really do is look internally and say, why are these things impacting me the way they are? And how can I reduce the amount of influence that they have over me? And that's a nice quote from Kathleen Braza here. Grief is a process not easily acknowledged in our society, particularly the grief of experiences other than death. Yet grief is often an integral part of most life changes and experiences. I mean, life is to change, and change begets grief. So we really want to be equipped, whether it's for the ambiguous side or the direct side, to be able to handle those aspects of grief as they arise. And this really goes hand in hand with developing an understanding. Now, when I took this job, oh gosh, like 3 years ago, we had this phrased a little bit more like acceptance. And we get it, but we don't want to imply that you're happy with the change in ability or the disability. We don't want to imply that you have to be set within whatever this new normal is. Instead, this really implies that you are able to adjust to the situation because you understand your strengths and you understand your limitations. And this is really defined by what your goals are, what the environment you're in, and implying that you are able to adapt within that new environment because you have a better understanding of what you can do and what you might be harder with, or what you might have more challenges with. It's also very important we address that it's not only the survivor that's adjusting, the caregiver is adjusting just as much. And many caregivers, I know I'm speaking from experience here, may feel inadequate or inexperienced, saying, "Well, I don't have the history to support my loved one." And many folks may be offering far more help than what that survivor is willing to accept. And oftentimes, this is going to lead to some changes in that relationship dynamic, especially among spousal relationships. Maybe leaving the person with a little bit more financial stress, as now they're spending more time caring for their loved one that they would have been working before. Or maybe changes for what their plan with their loved one is, what their dreams for the future are. And of course, given the nature of something like brain injury or stroke, many survivors may project their frustrations onto their caregiver, which oftentimes is not intentional, but it's really because that's the person in closest proximity to them. I also think it's helpful we say that caregivers are constantly balancing the scale you see here. Now, this is called the dignity of risk, and this was coined back in the 70s. The idea here is that we're balancing the scale with the person's need to take their own risks, to be their own decision maker, with our need to make sure that person is safe and secure and healthy. And as I'm sure you guys can guess, this is often a really challenging scale to balance, because if someone wants to take that risk, they want to try something that might be risky, then ultimately we have to make sure to give them that opportunity to fly and fail while making sure that we can serve as that net to catch if things go awry. And as we talk about this process of making good decisions, having changes after the injury, I like to say that your perspective of these changes can really change everything about how you look at them. So I like to show my fun little optical illusion. Usually when I do, about half the room will tell me they see a bird. The other half of the room will tell me they see a rabbit. If you're having trouble seeing one or the other, you can either see that as the beak of the bird or the ears of the rabbits and the nose on the right-hand side. But I show the silly image to say, the image doesn't change, but if you change the way you look at it, you can see something different. This is going to be very similar when we talk through this common question of, is this a troublesome behavior or is this a symptom of the stroke? So in the left-hand side, you'll see how things are commonly categorized as a behavior or a troublesome behavior. And in the right, how we can more accurately reflect those by individual symptoms. So I know in our work, we certainly hear things like, your survivor is having meltdowns. Now, realistically, the person is not melting down per se. They're having a mix of many symptoms. It could be the sensory overload piece. The lights, the sounds, the smells are too stimulating and it's setting them on edge. But it could also be the emotional regulation piece, where that emotional brain is not doing what it would have before. Not to mention, more simply, the person could maybe be overwhelmed by all this new stuff they're having to work on, or frustrated by all these new difficulties they weren't expecting to have to take on. Or it could also be the piece of making inappropriate comments. I mean, let's be real. Brain injury survivors do at times make inappropriate comment. But if we can simply understand this is an impairment to the judgment, the reasoning, the filter, it can take a lot of those hurt feelings away, especially, again, within spousal relationships. And not following directions. I hear this one very often. Your brain injury survivor cannot follow through on the instructions we gave them. And often it's because the instructions weren't given in a suitable way in the first place. You know, if somebody has aphasia, I'm rattling off a laundry list of verbal commands, how can I expect them to just spontaneously follow those? If they've got a visual impairment and I'm giving them a laundry list of written tasks, I can't expect them to do that either. And of course, what I think I hear probably every week, your brain injury or stroke survivor has missed their appointment, we will not be letting them into our program. And again, it's because we're holding folks to an unrealistic expectation. If you have memory concerns, maybe we can't expect you to just spontaneously remember your appointments. Or if you have fatigue and you really have nothing left to give, how can we expect you to just keep pushing forward when you have nothing more? And really what I want to get at across the board here is almost always we can more accurately reflect what's going on with that person by looking at the individual symptoms and taking a step back from this idea of the troublesome behaviors. Now, let's say maybe a loved one or someone in your life is displaying a behavior that's particularly negative that is not tied to a symptom. What can you do there? I like to begin by looking at, is there a predictor? Is there a trigger? Is there a cue? Is there something that lets me know this is going to arise? There may or may not be, but this lets you better find what is the message, what unmet goal, what unfulfilled need, what remaining desire or frustration is this person expressing to me with this behavior? And finally, how can I teach them to communicate the same need, the same want, the same frustration without that becoming a barrier to them getting what they want? Now, of course, this is easier said than done, but a good one to keep in mind. And this brings us a little towards the end of our conversation, talking a little bit more about what some of these coping strategies are. When we come to the coping side of things, I like to use one of the formal definitions for coping, so bear with me here. You can think of coping as the constantly changing cognitive and behavioral efforts to manage demands that are viewed as exceeding the resources of the individual, which is a mouthful. But basically, something seems beyond your ability to control or beyond your ability to influence. Coping are the skills we use to manage how we deal with that. And there are a few different types of coping. One of the big ones is problem-focused coping, or dealing directly with the situation at hand. So this could be maybe you're trying to get some more info, or trying to gain some more skills, you're trying to alter the environment to reduce the stressor. But in order to do this well, we need to make sure we're remaining open to advice, to criticism, and that we seek help if we're feeling overwhelmed or like we've got too much on our plate. Whereas on the flip side, we can also see emotion-focused coping. And this would be more like dealing with the emotions that arise due to that stressful situation rather than dealing with the situation itself. So this could be maybe altering the perspective like we just talked about. It could be maybe not blaming others or trying to reduce the stress and regulate those emotions. So as we talk about the problem-focused coping, that could be you're working on time management, you're creating your to-do list, you're trying to ask for support or establishing boundaries. Whereas on the emotion-focused coping side, that might be giving yourself a pep talk, meditating, taking a bath, so on and so forth. And there are both good and harmful aspects on both of these. As we talk about what's typically associated with healthy coping or helpful coping, that'd be things like self-distraction. You can't change something, so you distract yourself. Using your resources and leaning into your support network. Looking at situations from a new perspective. Also using humor, using religion or spirituality, and trying to plan things through. Those could all be really healthy coping skills. Whereas on the flip side, we can see some of those more harmful coping skills, things like denial, maybe avoiding the situation. Very commonly, things like substance use, blaming yourself, blaming others, withdrawing from activities or events, self-harm, and even things like impulsivity, often that lack of moderation. Now, there are a number of factors that are going to change which of these skills a person uses when. For one, that person's self-esteem. If they see themselves having a lot of ability to control this stressor, they'll probably take a different reaction than what they would if they didn't feel like they could. Not to mention the coping skills practiced. If stress is really high and all you've really practiced before are more harmful coping skills, it can be really hard to adjust to something helpful when that stress is already high. And of course, the time since the stroke or time since brain injury, the type of brain injury or stroke can certainly impact which of these skills we use. Not to mention the more tangential factors like aging and comorbid conditions or other conditions that come up as we age. Financial stressors like what is insurance going to pay for? What is my job able to give me flexibility on? And then of course, caregiver availability. Now, when it comes to these coping strategies, we see the most positive changes and perspectives after stroke being associated with the use of those more helpful coping skills, leading to lower levels of distress and leaving the survivor to feel more control of that stressor and in control of their life. And by and large, Those unhealthy coping strategies have a tendency of being the quick fix. They feel good in the moment, but often have those more long-term effects as we're not dealing directly with the situation. Now, again, this comes back to the dignity of risk, because at the end of the day, you are the deciding force on which of these are going to be helpful and which one won't. And we're not going to be the arbiters to say this is a good coping skill or this isn't. So we really want you to experiment, find out what works, find out what doesn't work, and preferentially lean toward those more helpful coping skills. And of course, coping and adjustment strategies are broad, and there's a variety of ways we can work on our adjustment. Of course, I'm preaching to the choir a little bit as we're all in the support group today, but really any sense of community engagement can be really beneficial. Not to mention things like employment to find that sense of purpose. And really importantly, acknowledging those strengths and limitations and reflecting on what are my dreams? What are my goals for the future? And one of the most important ones is continuing to engage in life stage appropriate activity. If you're, say, 35 years old and you had a stroke, that doesn't mean you need to stop engaging in things that a 35-year-old could do. We really just want you to avoid those particularly high-risk environments that could result in a secondary brain injury or secondary stroke that further muddies the waters. But we want you to be able to engage in those things that help to refill your cup and keep you motivated to move forward. And making a list of needs and wants is one of the best ways to do this. Really thinking, what do I need? What do I want for the future? What is the picture I have for myself in the future? And to get there, what kind of services are needed to help me get to that highest level of independence? If these are going to be outside services, what am I eligible for? How am I going to pay for it? And how can I make sure these services can be given to me without denying attention to the other people in my life or my family? And what kind of skills do I need to work on to help this process? And of course, as we get to the end, I always like to go through the signs of a stroke again, as if you guys are going to take anything from this session, we certainly say we hope it's this. So with this, the signs of stroke would be the balance loss in one or both of the legs, the eyesight changes, often in both eyes, but can also be in one, the facial droop or the smile test, arm weakness, speech difficulty in both the production and reception of speech, and T for time loss or T for terrible headache. And I also think it's really nice to talk through some of the exciting emerging treatments when it comes to long-term stroke care. And one of these is the first ever FDA-approved treatment for chronic stroke symptoms, specifically regarding upper arm mobility or upper limb mobility. So the idea here is a VNS or a vagal nerve stimulation device. So to keep it short and sweet, a microtransponder would be inserted into the pectoral and fed around the back of where that vagus nerve goes up to the brain. Now, the way I've had this described is you can kind of imagine it like a physician clicks a clicker and it bathes the brain in good chemicals. And those chemicals function a lot like fertilizer to help create new connections in the brain. So then the goal would be you pair this treatment with physical therapy, and it helps the body and brain bridge some of those connections that might have been lost as the result of a stroke. Now, due to the bounds of my position, we won't be giving any specific treatment providers here today, but do feel free to give me a holler if you have questions or you're looking for something in this regard, as there's a lot of cool new stuff coming out for the long-term stroke care. And of course, we are not the only stroke resource out there. There's us at the Minnesota Stroke Association, but we also have our friends at the Minnesota Stroke Registry, our wonderful colleagues at the American Stroke Association, and the Stroke Support Association. So don't hesitate to reach out to us or any of these other folks if you could be in need of some more support. And let's summarize. So every injury to the brain is unique and impacts the person a little bit differently. But if we're able to recognize those signs of a stroke, it's going to be all the benefit to our long-term recovery outcomes. And by focusing on the symptoms and keeping ourselves actionable with those symptoms, we're going to see a lot more success in those outcomes. And probably the most important thing I say at these sessions, I meet hundreds, if not thousands, of survivors every year, and I can't tell you guys the amount of grief that these folks give themselves. They'll say, I used to be the primary breadwinner. I used to take care of my kids. I used to take care of my folks. I used to work full time. And now I'm struggling to make it to the end of my week. And they're beating themselves up because they're trying to work from a brain they no longer have. And that's not fair. So instead, what are the shoes you stand in today? What are those strengths? What are those limitations? How can we keep you moving forward to highlight those strengths and reduce those limitations to keep that new normal as comfortable for you as possible? And of course, give us a holler. If there's more we can do for you, someone in your life, I always like to say, hopefully folks will never need us, but that's what we're here for in case they do. And we're over in Roseville. You can feel free to visit our website, give us a phone call, shoot us an email, whatever works best for you. And I did like to leave a little bit of time for questions. Any